I'm Tamara Thomas, editor-in-chief of UrbanHealthToday.com, part of the DocWire family of medical news sites, and I want to thank you for tuning in to Urban Health Weekly. Our goal each week is to keep you informed of the latest in health and medical news right from today's headlines. It's time to empower yourself with open conversations about your medical care with news that matters to you. So are you ready? Let's get started. Hi, I'm Tamara Thomas, and welcome to Urban Health Weekly, where we talk about medical news and health topics that matter to you. So I'm here with Lou and Jackie. How are you?
Good. Hey, guys. What's up?
All good over here. Raring to go. We got lots of news today, Listen.
Lots of news.
Before we get started, I just kind of want to tell you guys something crazy that happened this week. I saw a spotted lanternfly in my backyard. Are you familiar? Do you?
Oh, yes. See it and stomp it in New Jersey. That's how it works. See it and stomp it.
From what I heard, she took off her shoe, but
I took off. It was on my. I grow I have grapevines in my backyard.
They were all the way over there.
I was shocked that they were so far. I audibly gasped because I couldn't believe that I was seeing a spotted lanternfly in Brooklyn.
Wow, they're determined. There's plenty out here. They're beautiful. They're actually great looking and horrible.
Yeah, well, very distinct looking. And
yes.
I just instinctively, I just went, oh, and I took off my shoe and I went splat. Find the body, so I don't know if I succeeded, but I really gave it my all, just giving it like one, big, hit.
Good for you.
Crossing my fingers, I hope that I kill it because I don't want it mating and bringing other boys to the yard.
Spotted lanternflies.
To the yard, exactly.
That's the only one you've seen, just that one.
Well, I just saw that one. I haven't really spent that much time in the backyard, but I was out there because my dogs go back there and they hang out. And
yeah.
I, throw a little toy around for them and stuff like that sometimes. And I was just looking because they were because I had a bumper crop of grapes. And then I was
delicious.
Yeah, they are very delicious. I was just looking to see if any new grapes came in, and there were some new grapes. And then next thing I looked up and there was a darn fly. So it's just so weird.
It's gone now.
I don't know. I hope so. I'm crossing my fingers. I was looking around on the ground for the body.
Did you feel a crunch?
I didn't hear a crunch. I don't know. I don't know if I got it. It may have flown away. I thought I gave it a pretty good hit, but I don't know. I didn't see a body, so I can't really confirm.
Well, at the very least.
Let's hope. Let's hope they're not stubborn. You were telling me, Lou, that you heard something interesting in the news.
About what? About the flies?
Not the flies. About
Oh, today.
Yeah, about.
Oh, well. It's so breaking that it ain't even broke yet. But yeah, that's right. Moderna and Pfizer are suing each other. It seems.
Oh, they're countersuing.
Well, they're going at it.
Yeah, they're going at it. It seems that Moderna's upset with Pfizer. Well, it starts with Moderna being upset with Pfizer that the code for the vaccine or the secret sauce, I call it the McDonald's secret sauce, was kind of borrowed. Shades of Samsung and Apple.
Really?
So we're going at it right now. Pfizer's just denying it right now, but I'm sure they'll countersue within hours.
Oh, so they haven't countersued.
Not yet. That
when are they alleging it took place? Like right at the get-go, or is this the latest?
They say they copied the
whole mRNA.
Yeah, the whole mRNA. But how
in the devil did they get it? Did they hire someone away from
industrial espionage?
Well, it's industrial espionage. But there's something interesting also happened this week. That's somewhat related, but isn't related. Biden signed a law that says that all scientific information now has to be open access. In terms of scientific journals. So if you publish a study that's using U.S. funding, so if the NIH does a study and you publish it, it has to be open access for everybody to look at. You can't hide it behind the paywall.
Okay, that's good.
Yeah, so
I didn't know it wasn't already open access. I didn't know that. I thought once it was published in a journal.
Well, there have been the fight has been going on a long time.
Okay.
And there have been some suits that were unsuccessful in maintaining their paywall. So that may be what you've been seeing.
Oh.
There's
Well,
pockets here and there.
Germany,
Yes.
there's entire countries. Germany, most of Scandinavia have all passed laws that say that, hey, if they sponsored it, it can't be behind the paywall. And it doesn't really, what it means is like, you know, like if you're ever on Twitter or whatever, Facebook, and you go on an article and you start reading it, and then after like a paragraph, it says, if you want to really read this article,
Oh yeah, all the time.
even if it's for $1, you know, but subscribe, blah, blah, blah. Scientific publishing is doing the same thing, and they have every right to do that. However, if it's government sponsored research,
yes, that's what I'm agreeing to.
So those articles need to be open access. The previously with the informally, all the scientific publishers kind of got together. Let's not call it antitrust, because
it's a little trusting. Okay, all right.
Well, the big ones are Blackwell, Springer, Verlag, Elsevier, and Lippincott, Williams, and Wilkins. And none of those, also known as LWW, none of those are US based. So they really have to follow US laws, where this does affect.
Oh, wait, they do or do not?
It may not, yeah.
Oh.
But if you have a US IP, they do. So it's kind of IP generated. So if you're in Germany and you're looking up an Elsevier content, you may see a different result than if you're in the United States. Anyway, getting back to what's happening with Moderna and Pfizer, if something is done via the pharmaceutical company without government funds, it is basically their property and their business, and they're free to publish it, keep it as a trade secret, blah, 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 blah. You know, industrial espionage rules reign supreme. If the government paid you, and if you remember, there was that whole operation, whatever.
Right, to get the research as quickly. Operation Warp Speed, that's right. Warp
Speed, where these companies did take money.
Yes.
This may get a little fuzzy. And I'm just saying it only broke today, but let's just see how fuzzy this gets. Because if that research was done with US funding, then that doesn't mean that the patent is not good. You can still own the patent, but the information is widely available. So, you know, take that one and people and put it in.
Take that in your IP and
take that in your IP. It doesn't really mean a lot.
Download it. And share it amongst your friends on the file share site.
Violate the holy order of our show. But as long as we're talking about Pfizer and Moderna, you know, there is the new vaccine will be coming out.
Oh, yeah. I was curious to know when that's going to happen.
September 12th.
Okay.
It's going to be made available to the public, just like the old vaccines. The only difference is.
Are they still stopping people under 50 from getting it?
12.
Oh, okay.
The new age limit.
So that means my little one can't.
New age limit
is
12.
That sucks.
It does have a new secret sauce that does incorporate the BA5. So the BA5 is somehow in there that it protects against. It protects you more against Omicron, which the other ones never did. So it has all the latest variants, which viciously becoming like your annual flu.
So what was it again? Is it 6 months between like boosters?
Well, yeah.
Is it 6 months?
You have to have at least 6 months. And I know I had mine, I think, in April. I got to look at my card because New York State.
I didn't get one.
My kid got the booster.
I mean, I didn't get a second booster.
Oh, okay. My kid got the first booster in January, so he'll be eligible. Okay.
Yeah, my little one, she got her first booster. I think it was June. Yeah. So she's good for now, but I'm waiting for them to open this up. But they haven't done any trials on this one. They're just like going ham. Like
yes and no. I think
they haven't done any. They've not done trials. Basically, we're just saying, okay, since you've had such a good track record, we're going to trust you. So dig this, a man lost his ability to walk after vitamin B6 overuse.
Oh my God.
Yeah. How do you do that?
Good thing.
A man in Australia lost his ability to walk after consuming 70 times the recommended daily dose of vitamin B6. The 86-year-old man had previously been active and lived independently until a blood test revealed he had a slight deficiency in vitamin B6. He didn't have any symptoms of poor health, but his doctor prescribed a 50 milligram vitamin B6 supplement to his levels. Vitamin B6, like other B vitamins, helps the body convert food into energy by breaking down carbs and protein. Research suggests it can help the body's immune system and certain brain functions. Now, keep in mind, the gentleman was 86 years old. 50 milligrams is much higher than the standard dose recommendation in both Australia and the US, which is 1.7 milligrams of vitamin B6 per day for men over 50. In fact, most people should get enough B6 through eating standard foods like chicken, potatoes, or even spaghetti sauce. Time out, though. Time out. Today's food does not have the nutritional value it once had. Well, maybe in Australia, it might be different because they don't go by the same low standards that we have here. But usually, industrial food production really significantly cuts the
what is it? Saps out the nutrients.
Absolutely. Yeah, because if you're eating the chicken feed is not going to be as nutritious as it once was, right? If you're having the tomato sauce, the spaghetti sauce, those tomatoes are not going to be as nutritious as they were 50 years ago. Same with potatoes. So yeah, you'll get some B6, but again, I don't know what the standards are in Australia, so I can't really say for certain that it's the same deal as here. The new high-dose multivitamin wasn't the only B6 in the man's diet. He was also taking a magnesium supplement, which contained B6, and he ate breakfast cereals fortified with B6. Within months, he started losing the feeling in his legs and eventually went to the hospital after he could no longer walk.
Dang.
As the wellness industry expands and demand for dietary supplements increase, more Americans are falling ill due to taking too many vitamins or supplements. The number of calls to poison control centers about kids who took too much melatonin rose by 530% in the past decade. Preventive care experts say vitamin A supplements cause more harm than good, as taking too many can lead to bone pain and hair loss. Most Americans are not deficient in B6, thanks to naturally occurring B6 in a variety of common foods, according to Harvard Medical School. Certain medical conditions like alcohol dependency and autoimmune disorders can make individuals more susceptible to a vitamin B deficiency. But deficiency in the vitamin can cause inflamed skin, a weakened immune system, and depression. Nerve damage from B6 overdose is rare, according to the American Academy of Neurology, as the water-soluble nutrient typically gets peed out when taken in excess. Yeah, that's what I thought. I thought that
I wonder if this guy wasn't able, because of his age or some complication, couldn't pee it out.
Yeah, I think he wasn't adequately getting rid of the B6 because, when you're that age, things just don't work as efficiently. But again, this goes back to medical doctors not having a background in nutrition. I mean, a slight dip in your vitamin B, but he didn't have any symptoms. It's not like he came in presenting with like super dry skin or, some other kind of illness. Like he was fine. He had no issues. I think he should have just told him to, just up his, his nutrients or whatever, and come back in 3 months and we'll check your B again. But again, that's what happens when medical schools cut out the nutrition part of the curriculum.
Well, again, I'm gonna kind of.
At the very least, he should have been referred. If he felt so concerned.
Okay, if your doctor tells you you're deficient in iron, do you eat an anvil? I mean,
no. You're saying that he gave him way too much.
The guy took 70 times what he was supposed to take.
Yeah.
I mean.
No, he was instructed to take 70 times. 70 what he needed.
Okay, yeah. Well, if he was instructed, then there's a malpractice there.
The doctor prescribed it.
And I believe there's idiocy there, because we've got so much research that shows that mega doses of vitamins don't work.
Any vitamins, yeah. Mm-hmm.
Yeah, you have to drink like Lake Erie worth of water just to get it out of your system. It's ridiculous. Yeah. So it's bad news.
Yeah, so it's really sad.
Well, folks, now you know. Maybe take a little bit more than the USDA, but stop it. Stop at a reasonable number.
Yeah, see, I'm reading here. B complex vitamins are essential for functioning of the nervous system, and supplementation is generally well tolerated. Although rare, excess pyroxidin can lead to a paradoxical neurotoxicity, resulting in irreversible sensory neuropathy.
That's awful.
That is awful. You know,
I didn't know that there were kids who were taking too much melatonin, that was up by 530%.
I've been reading that. Well, you know what's happening is that kids are overstimulated. You know,
Yeah, I'm sure parents are just like, take this and go to sleep already.
right, exactly. Between the food supply being what it is, and kids everywhere you turn have some device. Kids are just not going to bed at the time they used to go to bed.
That's a big deal in our house. It's hard. It's hard.
That circadian rhythm is just completely off, and then you're desperate to get your kid to go to bed, and you give them a little melatonin to like help them go to sleep, at a decent hour.
I saw in an article where it talked about the overdosing of melatonin. They talked about that it was especially in young boys. And I'm thinking, I could just see those young boys bouncing off the walls and the parents being like, oh my God, I'm so tired. Please just go to sleep. Yeah. I could just see it.
Not just boys. That's me every night. You have to go.
Yeah.
Why do I have to go to bed? Because it's bedtime. Well, why?
I'm not tired. I promise I'll go to sleep in a little bit. No, right now.
Oh, listen to this. Most calls involve unintentional overuse in boys under 5 years of age and were managed at home.
Are the ones, is it chewable stuff? Like, because they're like a little bit sweet and chewable.
Yeah.
And yeah.
For kids to take.
Yeah, probably got the bottle and ate it all.
Yeah, just like those old kid vitamins that are like
that's
tasty.
What happened? They got a hold of the bottle because I was like, how could you have a melatonin toxicity? So maybe that's what happened. Maybe the kids got like,
I can tell you, I eat my vitamins, gummies, and it's always so tempting to like just
have more than
call
one.
it a snack.
You
Yes.
know something funny? I used to get these B complex gummies. They were so delicious.
I remember those.
Like, snacking them. It was like hair, skin, and nail something. And I was like, I can't buy this anymore because I can't help myself. They're so delicious. I just eat them like they're a snack, and I don't want to have some sort of
like
toxicity.
Cough drops. It's you don't need.
Or like Ricola or something like that, where you just like.
Where you just like it
because they're just so dang tasty.
I'm surprised you guys like those that much. Oof.
Well,
certain
I mean,
flavors.
Yeah, I like the lemon ones. Those are. That's the only one that I do buy is the lemon one. But they're still there. Like the bag is still there. Like even the last time when I had COVID and I was sucking on those, I still have the bag. I just hide.
All right, you didn't go through the whole bag. There's some.
No, I just had a few. I have to hide it though because otherwise my little one, she'll get.
Yeah, because that's yummy if you're not used to sugar. Kids just have an insatiable appetite for sugar.
And a lot of adults too.
Mm.
So should we take a break? Yes, we'll take a break and we'll be right back. And we're back. And let's talk about the silent spread of polio in New York.
Yikes.
What now?
Yeah, they found it in the wastewater or the sewage or something like that. That's where they're finding this stuff now.
No, but they did find one case.
They found one case. Okay, so let me get into it. A polio case identified in New York last month is just the very, very tip of the iceberg, and an indication there must be several hundred cases in the community circulating. The case was found in Rockland County, which has a stunningly low polio vaccination rate. Dr. Jose Romero, director of CDC's National Center for Immunization and Respiratory Diseases, noted that the majority of people with polio don't have symptoms and so can spread the virus without knowing it. A team of CDC disease detectives traveled last week from agency headquarters in Atlanta to Rockland County, and they are quite nervous that polio could mushroom out of control very quickly and we could have a crisis on our hands, said a community health leader who has met with the team. Polio can cause incurable paralysis and death, but most people in the US are protected thanks to vaccination. Others, however, may be vulnerable to the virus for a variety of reasons. Unvaccinated and undervaccinated people are vulnerable. And the polio vaccination rates in Rockland County and neighboring Orange County, just north of New York City, are about 60%, compared with 93% nationwide by age 2. Immune compromised people can be vulnerable even if they are fully vaccinated. This doesn't speak well of us as a nation. Wouldn't you agree? A disease we eradicated in 1979 is making a comeback. Okay. That's ridiculous.
But I'll tell you, this is kind of
come back and cripple little children.
Okay, first of all, I want to talk about two things. I want to talk about is the first thing is that we monitor the wastewater just to make sure here in New York, just to make sure these diseases, and we can tell how much of a disease is rampant or not rampant or going on.
And any new variants that are coming down the pipe.
Some of it is
no pun
cool
intended.
that we do it, but some of it is a little big brotherish too. It's a little creepy that they're going through our wastewater. It's almost like they're picking through our garbage and seeing what we're eating and giving us.
But isn't that hasn't that become like a standard public health thing?
Yeah,
it has.
Because it's not like people are volunteering to come forward and get tested. People are barely vaccinating as it is.
Yeah, so let me get into the demographics of Rockland County, and I'm not going to say which groups with an S, and I'm stressing the S because there's two religious groups there that make a large.
No more.
Well, two of them, and they make a large percentage of the population when you add the two groups together, and both are extreme anti-vaxxers.
Anti-vaccine, yeah.
Yes, anti-vaccine. And they, when these groups do this now it's becoming multi-generational.
Mm-hmm.
One of the reasons they fled New York was the city schools were demanding
vaccinations. Yeah.
Yes.
And they basically took up their camps and said, we'll show you. Went to Rockland County, which was a little friendlier, I would say, in terms of them setting up their own schools.
Own schools, right?
Yep, and home schools and their own schools, and vaccines.
I remember there was a little construction kerfuffle for some time because they were building the types of buildings that they built that they're used to building, and it wasn't
here
in
in New
keeping.
York, it's like
it wasn't in keeping with the area.
Well, if you go there, and the area itself,
it wasn't contextual.
Yeah, the area itself is like the wide open plains. You get a house every mile almost,
And they're building
and then
buildings.
all of a sudden you see this cluster of buildings, and you go, that's exactly like New York. It's like, okay, so our bad architecture made it here, and it's just like it's like in the middle of nowhere, and then you see like these buildings and a cluster of them. And
it was like cut and paste, huh?
Yeah, you wonder like what it's like one of those sci-fi movies where like you're in it's or like Wanda or whatever on sci-fi where some they're like, what is this all about? So there's a few of those on.
So your point is that it's been being driven by certain populations.
I think it's not only the certain population that now this has become multi-generational. And it's multi-generational of no vaccine. So if nobody in your community is vaccinated,
boy,
come out. It's just somebody's gonna bring it in from somewhere, and all of a sudden there you go. You got case one, and then unfortunately these vaccines are only 95% effective. So think of it this way.
How long are they accurate for? I mean, how long are they effective for? So like, I know I haven't had a polio vaccine since I was like a kid, I'm pretty sure.
New York City's actually doing boosters right now. They're recommending
for adults.
No, for children, because children are, I haven't seen any adults suffering from polio unless they had it from childhood.
I don't know enough about the disease to even tell you the symptoms for an adult. For a kid, yes. But
it's the skinny little legs, and you lose your ability to walk.
I remember iron lung and all that stuff, like all that footage.
Yeah, and there were a lot.
Isn't that what took
special shoes were very
President
common.
Roosevelt, Delano?
Yes, that's right. He got polio.
Yeah,
that's right.
Yeah,
but he had it as an older adult.
Right, you could get it as an older person, as a grown up. Yeah. That's why. But I guess it was just famously more devastating, or somehow it just seems like more kids.
Wait, he got it as an adult?
Yes.
Oh, wow.
Yeah, he was in the prime of health and he got it.
Oh, that's right. He was quite the athlete. Okay, yes.
Mm.
Well, yeah. So the push is to vaccinate children. I have to read
But again, we're going to get into one of these
I
debates.
have to read the Department of Health.
Can we force, people?
No,
because there's a lot of religious and exemption, etc.
and there's a lot of
Just
objection,
COVID
and there's a lot of exemption that has nothing to do with religion. It's just like my immune system is terrific, and I don't. We've got, what is it called? Conscientious objection. Yes, that's it. Where people are just like, I don't want to do it. I don't want to do it.
You guys have that in New York?
Oh, absolutely.
We didn't have that. I don't think we have that in New Jersey. Not for nothing. We have, you could have a religious exemption. I think you have to say something is your personal religious belief in order. I don't think there's medical exemptions.
Now it's just, I just don't want to do it.
Wow.
Yep. And that's it. And that's why we have all this disease spread, all these diseases coming back that we had eradicated with vaccination. But I think that started with that. What was that? It was the autism, the whole thing with the guy, and he did the article about autism, and it made a lot of people really scared about getting vaccinated. Remember
that was for the MMR. Yeah.
Oh yeah.
Yeah. They published it in the Lancet or one of those big publications.
Yeah.
It became like a huge deal. And I think they had to strip the guy of his credentials and stuff.
And he was related somehow to one of the Kennedys. Oh, it became a whole mess.
And that is where the genesis of this anti-vax movement began. People were like, I don't want my child to get autism. And they avoided, and they said to themselves, hey, you know what? My kid is okay. My kid hasn't gotten as sick. My kid is perfectly healthy. I'm just going to continue to rock with this, and that's where it began. What are you going to do? I still think this doesn't speak well of us as a nation. I think we all have a responsibility to one another. There's a reason it's called herd mentality. I'm sorry, herd immunity.
Herd immunity, right.
The herd mentality. You said it right. The herd.
That's what we don't want.
Starting our herd immunity because we got dumbass heading the herd.
Thank you. There we go. What has 308 pages and discusses everything from pregnancy to Medicare Part B? It's the proposed rule from the Department of Health and Human Services implementing the non-discrimination parts of the Affordable Care Act, or ACA. The proposed rule, which was published in August in the Federal Register, implements Section 1557 of the ACA, which addresses non-discrimination in healthcare. The Biden administration has interpreted that section of the act very expansively, which means that the rule would cover a wider range of healthcare providers than it did under previous administrations. For example, it will apply to Medicare Part B providers for the first time and will require physicians to not be discriminatory in all these ways. Marianne Tomasic, JD, MPH, clinical instructor at the Harvard Law School Center for Health Law and Policy Innovation in Cambridge, Massachusetts, agreed. This proposed rule is a lot stronger and a welcome change for many, she said, adding that it expands protections for several groups, including people who are LGBTQIA. Discrimination manifests itself in the healthcare system in many ways. Patients can face physical or linguistic barriers when they try to access care. Some patients have health insurance that will categorically exclude care related to gender dysphoria or other diagnoses. We've also seen patients have insurance plans that will take groups of drugs used to treat a certain chronic condition like HIV and put those drugs on the most expensive formulary tier, leaving the patient and the provider with no affordable options for treatment.
Wow.
I know. It's pretty. The proposed rule will result in a very strong final rule that prevents these situations from happening, and where it doesn't, explains how people can seek redress. So wait a minute. I just want to know. So how do you stop people from being prejudiced or biased? How do we?
Obviously, with the 308-page edict, that's very heavy.
Let me tell you.
And they hit you over the head with it.
That's a very tall order because the view on who is worthy to cry discrimination is so narrow nowadays, don't you think? It's like, You have to be like an underserved population. You have to be a person of color almost. I'm just wondering, like, what if you're a patient that doesn't recognize that it's happening to you, right?
Yeah.
Then what do you do?
A lot of people just take it for granted, or just, you know, turtle up and just forget about it. Just say,
It took me years to personally to recognize when I was being discriminated against. And when I look back on some of the issues, not that I feel,
that takes a certain amount of life experience and
Right,
just like wisdom.
exactly. And I wasn't really raised that way because I didn't really have
Right.
growing up. And it's not until I got older and went out into the world, but I took me a long time to recognize it.
You have to know what you're looking at. You don't always know what you're looking at.
And then if you're a woman and your doctor is gaslighting you because you're a young woman complaining about pain, is that covered? Or do you have to be a young woman of color for it to be
apparently not covered?
That's what this is what I'm trying to get at. That does this go far enough? Does this
how do you legislate that though?
That's what I'm trying to figure out. It all sounds very wonderful and pie in the sky.
It sounds wonderful, but let me just give you my perspective here. If this was a 3-page edict, they say, yep, it's understandable, clearly written, and it's going to work. It's a 308-page thing.
It's a tome.
Yeah, a manifesto. I mean, honestly,
manifesto.
Yeah. Well, nobody's going to understand it or go through it, and God knows what's in there, and I'm sure it's contradictory or unclear stuff.
Yeah.
You know, people that don't know how to write or do these very long-winded, complex,
and lawyers are just going to pick right through it.
Lawyers are going to have a field day with it, like as you say. I feel that if this was a 3-page edict, I'd pay attention to it. 308 pages, nobody's going to know what the heck it says.
What do you think, Jackie?
Well, what I'm going to ask is, so are you saying this is just window dressing? It's like, look, we're getting things done to look busy.
That's not what I'm saying. I'm saying that in theory, it sounds really good. I'm wondering if in practice, it will actually do what it purports to do.
Okay.
Who does it actually protect? When they were creating these 308 pages, who did, in law, they always say, well, the founding fathers didn't envision this when they wrote this and that.
Right.
People always say that. Who did they envision they were protecting when they created this? Who did they have in mind? That's the question that I'm asking. How do you legislate prejudice? How do you legislate bias?
I think they had themselves.
Everybody has personal bias.
Themselves in mind.
And everyone has blind sides.
And well, the reason it's themselves in mind, they all want to have their name on it so they can say, oh, I pass some legislation. But it doesn't work that way.
I mean, do you see the benefits of it? I'm not saying
if you put it down, then you can be like, see, there is, it says specifically right here, this group cannot be discriminated against for this reason. If you don't make a tome, then then it's not quantified. Somebody's got to specify and point to a rule, don't you think?
Yeah, absolutely. I just, want to make sure that everybody who has experienced, because look, the young white woman who got gaslit by her doctor only to find out months later and 3 doctors later that she actually had cancer and it wasn't in her mind. What does she get protected by that?
I guess that would fall under the category of malpractice, but not this necessarily.
Oh.
But why not?
Well, this is
because it's ageism.
This is technically more like, I don't know if this is actionable in terms of lawsuits. I'll give you an example here that the medical does follow. When the societies come out with their guidelines, which we know are very important because that's what doctors use to treat you, so that they don't get sued. Because if they're treating you within the guidelines, it's very, very difficult to sue them. Because they go in court and says, well, our profession's guidelines are blah, blah, blah. Who's going to challenge, ASCO or the AMA or ACC
or ACOG or something,
What they found, though, was that these guidelines were so complex that it did lead to lawsuits because physicians couldn't fathom them or they were contradictory. You got to pay.
Oh, they were afraid to, they misinterpret it.
Right. So then what they started doing, and not only started doing, they still do this. was they went out to professional publishing companies, and the professional publishing companies would publish what was called the pocket guidelines, which is just basically the guidelines stripped down to what a practitioner needs to know and do. And the whole guidelines are there, but
So it's like in a pamphlet instead of a tome.
yeah, they call it pocket because they would fit in your pocket. But basically, they were a page and a half or something like that of what the important stuff is, and on hypertension is if your cholesterol is over 130, monitor, and if it's over 140, I'm sorry, blood pressure. If your blood pressure is over 130, do suggest a statin unless A, B, and C are present. It's down to that simplicity. But I don't see this 308-page document being distilled in that, and it's right.
Well, we don't know because we haven't looked, through the pages. But
I can guess anything that's 308.
I just want to make sure that all people are protected, and also, there's sometimes a fine line between bias or prejudice and kind of defeatist, like, well, I know the insurance is not going to pay for this. I'm not even going to order this.
Ah.
I mean, does that fall under prejudice necessarily? No. So I'm looking to see what this does. I'm looking to see who this helps. I hope it does the right thing.
It says in the 300 pages, it explains how people can seek redress.
Redress for what, though?
For prejudice.
But
you're right. I don't know. It's 308 pages.
But my question is, is it prejudice if your doctor looks at you age 20 and says, I know her insurance is not going to cover this test. They're going to say she's too young for it. So I'm not even going to bother ordering it because she's going to be stuck with this bill and they're just not going to pay for it. And she looks fine to me.
Well, that falls under the category of like, well, you don't fall into the category of age.
Right, but that's
what Lou was just saying.
But that would be okay. So then what's the redress then against the insurance companies? Because oftentimes some of this comes down to what you think the insurance is going to cover. Is that on the provider or is that on the insurance? Do you see what I'm saying? Like this.
Yes. Now I'm starting to really see it. Yes.
Yeah, there's some gray areas that people are still going to really fall through the cracks. And that's why I think this is going to be really difficult. I agree with Lou that
well, how would you fall? Would you say that's ageism?
Well, I would say that's ageism, but I'm not sure that that's where that particular doctor is coming from. Do you see what I'm saying? They may not be thinking that at all. They may be looking at, based on their experience with this insurance is just not going to pay for it. I'm not going to burden this person with this bill and dealing with the insurance. And so I'm just not going to bother ordering that test. But does that make them prejudiced? Does that make them ageist? Not necessarily. So you see what I'm saying? Like there's so many.
Yeah, that really makes it more of a health insurance issue.
Right.
I don't want to burden them. I don't want to, it's going to get denied.
Right. And this is talking strictly about providers and health centers. This is not covering the insurance, at least not as far as I've seen here, because a lot of this sometimes comes down to whether the insurance is going to cover it or not.
Sure.
And sometimes that's where the decision line falls, unfortunately. So I'm going to take the wait and see approach, and I want to see what kind of lawsuits, if any, comes out of this. I hope it makes the change that it's purporting to make. We'll see what happens. Time is going to tell, let's hope it makes the improvements. I feel like some of this is kind of band-aidy stuff and to make people feel better. Time will tell. We'll see.
Okay.
So we'll take another break and we'll come back. And we're back. And so hopefully the last segment leads into the subject of this week's topic, infertility, blind spots in medicine. So as editor-in-chief of Urban Health Today, one of my jobs is to create health disparity overviews for our health partners. And what they do with it is they present it to companies looking to learn about the disparity landscape for certain diseases. But an interesting one that we worked on this week was on infertility. So listen to this. And this is where it goes back to the HHS's barring discrimination in healthcare thing. I just want you to listen to this. So infertility is defined as the inability to conceive a pregnancy after 12 months of regular, unprotected vaginal intercourse. Assisted reproductive technology is a tool that can be used to effectively address infertility. The challenges lie in properly identifying patients to qualify for access to the technology across a myriad of fertility cases. Awareness of the needs of all fertility challenge groups is crucial to improving access. So let's look at the fertility landscape. Numerous studies have substantiated differences in ART outcomes between non-Hispanic Blacks and non-Hispanic whites. LGBTQ plus patients have specific needs and experience barriers to access to ART care. Example 1, queer women were likelier than straight women to delay childbearing or having fewer children, but were more likely to report delays or cancellations of contraceptive or sexual reproductive health care by providers. Healthcare professional bias in reproductive care assume queer women patients are not at risk for pregnancy or STI transmission. Untrained HCPs may fail to address transmasculine and non-binary patients' needs regarding how hormonal birth control containing estrogen or progesterone may interact with gender-affirming testosterone, and whether testosterone alone is a contraceptive, which we should know it's not. Male factor infertility is responsible for infertility in approximately a third of couples, with Black men having the highest rate of abnormal semen analysis. Men are rarely treated prior to entering a fertility clinic, despite recommendations from the American Society of Reproductive Medicine that both partners receive infertility evaluation at the same time. Female cancer patients exposed to chemotherapy are at greatest risk of future infertility. Despite this outcome predictor, disparities in counseling of female cancer patients for fertility preservation, FP treatment, prevail. Now let's look at the insurance. Despite agreement across multiple international medical organizations and professional societies, infertility is rarely treated as a disease in most insurance plans. The Patient Protection and Affordable Care Act enumerates multiple essential benefits that must be covered by applicable insurance policies, but infertility care is not listed as an essential health benefit. Insurers in the United States have long considered infertility a socially constructed condition, making in vitro fertilization, or IVF, an elective intervention. As a result, IVF is cost prohibitive for many patients in the US. The American Society for Reproductive Medicine estimates that fewer than 25% of infertile couples have sufficient access to infertility care. Isn't that crazy?
Yeah, and it's freakishly expensive.
Oh my God. Black women, who represent almost 8% of reproductive age women in the United States, are underrepresented among IVF recipients. ART procedures per million non-Hispanic Black women aged 15 to 44 for insured Black women stands at 0.27%, not 27%, 0.27%.
Wow.
Far below the national average of 0.44 and the average for non-Hispanic white women of 0.52%. Insured Hispanic women showed the lowest scores overall, with an average of 0.17%. Limited access to state-mandated insurance may be contributory. LGBTQ patients plus patients are more likely than straight patients to be uninsured. But even insured patients who visit medical providers who provide competent care may still face insurance denials due to gender markers in their patient profile. For example, an insurer could deny a transmasculine person seeking birth control coverage because, despite the presence of female reproductive organs, contraceptive care does not align with what the insurance plan categorizes as male or men's health services. Male infertility is rarely covered by insurance. Despite both sperm and eggs being required for conception, only 8 of the 15 states with laws mandating insurance coverage for infertility for men have legislative language that mentions the male partner. Men whose insurance does not cover male factor infertility will be less likely to receive needed infertility evaluations if their care is not a covered service. Excluding the male partner leaves the burden of reproductive care on the female partner and risks missing important reversible or irreversible male health conditions such as testicular or prostate cancer, diabetes, or hypothyroidism. Most newly diagnosed cancer patients do not meet the definition for infertility to qualify for FP treatment. They are in a unique situation because they know they are at high risk for infertility from their treatments, but they aren't infertile at the time they need the services. With the rise in younger women being diagnosed with cancer, this scenario is becoming increasingly prevalent across the US. Okay, so what do we think?
Is it going to be a case where only the wealthy can afford,
Is that
are
not,
going to be getting,
isn't that
yeah, that seems to be the case already.
Let
yeah.
them be more wealthy and less poor. I mean,
Is that come on, guys, you can do better than
no,
this.
I don't know anybody, by the way, who hasn't been affected by infertility in some capacity.
That's what
Everybody has a relative or knows somebody who's had it in some way.
the bottom line is the insurance they have not had their feet held to the fire. Even the federal government has not stepped into this
Also, I think it's a huge moneymaker. I just think it's a really good industry if if you're the doctor and that clinic. I think that's a very interesting and you can make a good living if you're a top-notch fertility specialist.
Yeah, and
am I wrong?
No, you're right. And
that's a good specialty.
Insurance doesn't cover it, and you've got to come up with the cash, and you don't have to. So you're not incentivized as the provider necessarily to petition the insurance to pay because
I think
you have a lower patient load and they're paying you cash money.
And I think
it's like plastic surgery.
There's a lot to unravel here. This is like an onion when you really start peeling it. There's a lot of factors, starting with the Hispanic, my people, that we have the biggest problem when you look at all the groups,
right?
And B, knowing culturally is just something that's not spoken of. It's it's people are shamed if they can't do it. So at the end of the day, they'll hide the fact that this is not happening by saying, "Oh, we're just not trying," or
by praying to Papa Dios.
"Oh, we've decided not to have any," or Papa Dios, as you say, God for those. That's one of the Spanish inclinations. So it's just not discussed. And going to the doctor may be something shameful for the couple to do. And as you said, it's really, the recommendation is both go. So the man may think, well, it's your problem, that's,
but that's kind of the attitude that's taken, that this is strictly women. So now, because, and it may very well be the man.
33% of the time it's the man.
Right. Because the men are not being tested, the women now have to go through all this additional testing.
I had an aunt. Yeah, that was her situation.
It may not even be her.
Yeah, it probably wasn't my aunt. Yeah. She had to go through tons and tons. And that was years ago. So that was like the dosages were so much higher back then because they didn't really know about how to they overdid it on the hormones. They didn't necessarily know the proper balance. And think of all the people now out there who just have mild to a little bit of PCOS. That is so common.
Yeah.
That's so common. And that's really only going to be more people with all the endocrine disruptors out there, with just more people with type 2 diabetes. All that stuff affects fertility. More people with thyroid issues. This is only going to be a growing area. More people are going to have difficulty with infertility.
On the man side right now, as you correctly said, diabetes, obesity, and those affect social groups many times that are, have the least amount of insurance and have the least amount of resources.
Right.
And, it costs a lot of money to eat healthy. It's like, it's difficult. Even if if you make your own ketchup, I found out today, you still got to really good ingredients, you know.
Yes, stevia is
And
expensive.
it's stevia and you know, organic tomato, but it costs you more to make the ketchup than it does to buy the damn thing. So at the end of the day, a lot of people, some of this care may be beyond their reach.
But the reason it's beyond their reach is what I'm trying to say is because the insurance industry has been given the carte blanche to, because think about the role of insurance. Insurance's role is to make as much money and pay as little as possible. And they've been given wide berth to deny all manner of stuff. Now, despite the fact, if you have a transmasculine patient, despite the fact that the medical records clearly shows the person has ovaries and does need contraceptive care, they're being denied. They're being denied. They're not being denied because you're a man. They're being denied because insurance doesn't want to pay. And there's no one holding their feet to the fire to say that you need to pay.
Remember, your average physician
So
is
again,
55.
but again, this goes back to right. But again,
Wait, is that what it is? Is it the 55-year-old average age insurance provider?
No, the average physician is 55 years old. And I'm just saying
the average specialist or the average
physician. The latest time I checked was
what kind of physician?
Any type of physician.
Okay, so the
Because
average age of
remember,
all.
So you think that they have maybe like older way of thinking?
Well, you know, you were trained. Well, look, this stuff didn't start coming out from now. If I would have gone to medical school, you know, the number of trans people, there was Christina Jorgensen. And
yes, that's true
like
too.
3 trans people in the entire planet that we knew about. It wasn't
the entire planet. Come on.
That we knew about, that was public, that was famous.
That was public, but you know, it just didn't happen that much.
You mean people weren't out about it?
We weren't aware of it in the public media. Yeah.
And you know, it was such an outlier that, you know, it just wasn't covered in medical textbooks. And it's only now that it's starting to be covered, if it's covered at all, because I don't know.
All right. So then let's pivot then to something that is very well covered. The fact that women who undergo breast cancer treatment lose their fertility.
Okay, yes.
Yeah. So they're in a catch-22 with the insurance because the insurance is slick, like, well, now.
Yeah. Well, they call it an elective, or they say, well, that's the social.
Even though the science shows that they're at very high risk for losing their fertility, they won't pay for the FP treatment.
But I think this
has nothing to do with the age of the doctor.
This is on the oncologist. And I think that the oncologist needs to.
Yeah, they do bear some responsibility, but insurance has a lot of leeway.
But if the medical profession pushes insurance usually backs down.
Really?
Oh, yes.
The state has, if the state, okay, so for example, here in New York, if you have the BRCA gene 1 or 2, the law is you as the insurance, you must say how high when the physician says jump. And that's the law of the land here in New York.
But that's because there were activists. Is that the activists or the doctors who came forward and said?
I'm not sure, but I think it's a recognition that, you know, lives were being lost because of insurance doing their tricky dicky, not paying for this and not paying for that.
Something becomes part of the medical guidelines and treatment protocols and all that, which are very public, and these are official documents the societies do, and they update them every 3 years. And when something makes it into that,
but I'm not sure that I'm not convinced that this is across the country. Do you see what I'm saying?
There's 20 states that I believe that say to us.
And how many states do we have in this great nation?
50.
Okay.
So
wait, there's 20 states doing what? That say that fertility must be covered?
Not fertility. That's only 15 states.
Yeah.
No, that say if you have a mutation, a cancer gene mutation.
Okay.
That the insurance has to cover whatever those expenses are, including surveillance.
But I was referring to surveillance.
And the insurance, in some ways, have made a decision that it's cheaper to pay for the surveillance than it is to pay for the cancer care. So, you know, so
because it's managed costs again, as
right,
opposed to
exactly.
managed care.
Right. But when you get into fertility, not so much, you know, so there needs to be, you know, a great deal of awareness in not only the blind spots that the medical community, like, for example, I mean, imagine, you know, you're a queer woman and you can't get an appointment for your contraception because the doctor is assuming that, you know, well, you're only with women. What do you need contraception for? That's not their business. You don't know what I need it for. You know, so it's a combination. And so going back to the HHS 308-page tome, it still remains to be seen how effective that's going to be. That's all I'm saying. I'm saying that there's all these little nooks and crannies of areas that I'm not sure.
And I think that, you know, also medical societies need to kind of gang up on this subject.
Is that where it comes from? Is it the medical society that comes forward that makes the change?
So. Once they say something is so, it may take a few years, but it'll get done. And what happens is that a lot of these patients are being treated by, you know, primary care physicians, barely get to see
a specialist,
which is a gynecologist.
Yeah.
And remember, the fertility specialist is a specialty of a specialty.
Right. So first,
yes, it's like a fertility endocrinologist
or the urologist, and then maybe the endocrinologist, or the fertility.
Primary care societies, the ACP, the American College of Physicians. That's the AMA is everybody, but if you're a primary care doctor, you go to the ACP. Then you get sent to your OBG. And the OBG society is called ACOG, and they have 50,000. So the ACP has about 200,000 members. And these people do bear a lot of clout because they write a lot of scripts, and their economic power is very strong. Then you go to a gynecologist, there's about 50,000 of those. And yeah, they do a lot of stuff. They do birth control. They write scripts, but they don't have the power that the ACP does. Because we're talking about economic power. That's just how it goes.
Okay.
Then the American Fertility Society, which is a subsegment of ACOG, but they're their own group because they don't always get along. There's only 3,000 or 4,000 of those in the entire United States that just specialize in that. Now, they started as an ACOG member, but then they went over to AFS, American Fertility Society. Their economic power is not so big.
Yeah.
Not where they can change, not where they can change insurance. However, they are valuable to the drug company, very valuable, because there's only 2,000 of them, and those 2,000 really do prescribe a lot of their product, but they can't change anything.
But would it be beneficial for them, for the information that they have, to trickle down to the doctors that are referring to them, and ultimately back to the primary care doctors? So they're much more knowledgeable. So now you have a bigger set of doctors that are invested in this.
It all goes into the probing. And the probing has to happen at primary care, nurse practitioner. You got to ask the question, and the patient has to realize that those questions have to be asked.
Right, but I think that's part of the problem, is that the questions are not being asked because there's not enough knowledge out there about the questions to ask. And a lot of this stuff needs to become normalized now.
Right.
Is there a reason why insurance would not want to cover fertility? It's just the sheer expense?
They don't have to.
Is there some disadvantage? They don't have to. Is there something about not wanting people to start families? Is there like...
No, it's simply dollars and cents. They just don't want to cover it.
Well, is having people start families, does that just increase?
You won't die from not having a family.
Oh, that's it. Okay.
They die from
it's not life or death. Right.
They look at it as a selective process and they put it in the same category as a facelift or plastic surgery.
Yeah.
I mean, it's that, you know, like,
which is outrageous, but
it's ridiculous.
Yeah.
But
wow. Meanwhile, that's why they're saying it's social, it's cultural. But that's painful.
Yeah,
starting a family is so fundamental to so many people.
But you know, more of these medical societies need to band together and make a powerful fist and strike back.
So they're really saying that it's a privilege, not a right.
That's exactly what they're saying, and that's exactly why it is the way it is. It is a privilege for some people. But it should be open to many more people, and insurance can make that happen. So look, go to Urban Health Weekly for the links to these articles. I think you'll find a lot of this stuff very eye-opening. And remember, you only have one life and one body. Do your best to make it count so your years are full of life and full of health. Remember, people, information equals transformation. So small steps each day and you'll see a difference. I'm sure of it. That's all the time we have today. My lovely people, it's so good to see you and see you. It's so good to talk to you.
It's so good to see you guys. Well, talk to you guys.
And I'll talk to you guys again next week.
All right. Bye, guys.
Bye.
All right.
I'm Tamara Thomas, editor-in-chief of UrbanHealthToday.com, part of the DocWire family of medical news sites, and I want to thank you for tuning in to Urban Health Weekly. Our goal each week is to keep you informed of the latest in health and medical news right from today's headlines. It's time to empower yourself with open conversations about your medical care with news that matters to you. So are you ready? Let's get started.